Hey, Alicia, I have a quick question. We have 3 minutes. So from on your end, I was just reading through like my host notes that I was sent. Um, on your end, Q&A is at the end, correct? Like the end
It's
or
before I close out, from my
right.
understanding, unless
Okay.
we decide to do it at the end.
That's what I meant, like before you close out. Yep, culminating
Yes,
all of the speakers going, correct?
that's right. That's right.
Okay. And what
Yes.
time do you like this doesn't have a time stamp on it. What time do you have on your end? Does it have a time on your what you see for Q&A?
For Q&A, they wanted to leave, I believe it was 15 minutes.
Okay.
15 minutes for Q&A, yes.
Okay. So I will make sure that I set my alarm for 15 minutes.
And then each presenter is going to have 5 minutes for their presentations. And then we have questions for each of them, which may take a total of about 5 minutes for them to respond to.
Wait, do we have 5 or 15 minutes to present?
5 minutes to present. After the presentation, I'm going to ask each of you a question, and you'll have about 5 minutes to respond to the question.
Oh, I thought it was 15
So
minutes.
did I.
Yeah. Because otherwise that would be.
Q&A and sorry, Desiree, I'm sorry. Go ahead, finish what you're talking.
Oh, I'm for whatever you all want, but I just didn't know. I thought it was 15 because that would fill the whole hour with a 15-minute Q&A.
That's what I thought too. That's what I was told. So it's four of you all, right? So
Three.
three.
3 presentations.
Mhm.
3 presentations at 5 minutes each, right?
Yes.
And then
5 minutes for
And
Q&A.
then there's a panel of questions, so you'll have more time.
to talk.
That's right, after your
And
presentation.
and that panel of questions is not one at a time. I'm just trying to be clear because I feel like I'm getting lost here. That panel of questions is after we've all presented and they
That's
make
right. And so, for example, I'll say, let's start. Thank you all for providing insight on your programs. I have specific questions for each of you based on the information you shared. And so I'll say, let's start with Savannah from Black Women's Blueprint in New York City. You use a variety of means to reach women in the city, including mobile health vans and home visiting. Tell us more, including how these programs integrate with mental health providers, especially in a big city area like New York. And so that would be your question. And next would be Brittany. And so then you have time to respond to that question, 5 minutes. Next, Brittany from the Nebraska Maternal Health Program. Tell us more about the technology you used and how digital solutions are improving postpartum care for postpartum women receiving Medicaid services. And then I'll give you time to respond. And then the third question is, now Pamela from Bighorn Valley Health Center, as you told us, you serve the American Indian community. Tell us why you chose to use peer support specialists to support your program. Also tell us more about interactions with medical providers or the healthcare system. And those are all the questions. And then we move forward to the Q&A, and then I conclude and wrap everything up at the end.
Got it. And then Alicia, just for clarity, you want me to still share that slide or are you gonna share it at the end?
I'm more than happy to share it. Yes, I'll share it at the end. Totally fine doing that.
All right. All hearts and minds clear. It's 2:42. We like 2 minutes late. You guys good?
yes. Thank you for
Yes,
saying
I'm okay.
all hearts
Okay.
and minds are clear.
I'm gonna open up the waiting room.
And once you do that, Ebony, I should start.
Correct. Give everybody 10, 20 seconds to get settled. Yep. And then you're good to
Beautiful. Okay. Hello, everyone. Thank you for inviting me to moderate this conversation with 3 of the United States Department of Health and Human Services Racial Equity and Postpartum Care Challenge Award recipients. I am Alicia Blanks, Public Health Analyst with the HHS Office on Women's Health. I'm excited to facilitate this discussion, highlighting some of the strategies and accomplishments in maternal mental health currently, making it a positive impact in communities across the country. Improving maternal health outcomes is a priority for the administration, HHS, and the Office on Women's Health. The Racial Equity and Postpartum Care Challenge was established to address maternal health disparities and improve equity in postpartum care for Black or African American and American Indian Alaska Native women enrolled in Medicaid or the Children's Health Insurance Program, also known as CHIP. For this challenge, our office partnered with the Centers for Medicare and Medicaid Services to award innovative and sustainable projects that help to ensure quality healthcare during delivery and postpartum periods. We will now hear from our panelists who will share how they are addressing postpartum care in the communities they serve. They will also share lessons learned in terms of program design, implementation, and outcomes. Again, we have 3 of the competition winners on the panel today. There are programs across the country who were also awarded prizes for innovative, sustainable projects. A full list of the awardees and their location can be found on our website, on our blog at womenshealth.gov. I will insert that link in the chat box. Joining us today are Black Women's Blueprint, Sync Health, Collective Medical and Incenna, and Bighorn Valley Health Center, One Health. Can each of you tell us more about your organization's program, where you are located, communities you serve, what you are doing, what makes your approach unique, and how it's making a difference? We will give 5 minutes for each panelist to respond. Let's start with Savannah, the National Director at Black Women's Blueprint.
Thank you so much, Alicia. I think I have some slides to share with y'all. Again, I'm Savannah Brown, National Director at Black Women's Blueprint. You can turn the slide. We were founded in 2008 to ensure that all women can live lives of sovereignty and dignity. And our work is done in partnership with both mental health and obstetric providers in order to build racial equity and responses to postpartum and maternal depression, anxiety, and also early childhood infant services. And that includes our education and training for doulas and midwives, as well as medical personnel. You can turn to the next slide. So our program is really innovative in targeting gaps around diagnosis, around prevention and treatment during the postpartum phase, and we do it through a culturally specific lens. So we use cultural competence tools and mechanisms. We're responsive to poor and Black communities who are under-resourced and also simultaneously distrust medical communities. So we use a few different practices for intervention, which include mobile services, peer-to-peer postpartum depression interventions, and then life-saving devices and healthcare aid. Go to the next slide. A little bit more background around the problem. We're noticing that Black women in particular are experiencing higher prevalence of maternal mental health conditions, and that includes postpartum depression and anxiety. It's also largely underreported, and symptoms go unaddressed and sometimes undiagnosed. And we're seeing structural and social determinants are increasing and contributing factors for mental health in Black populations. Next. We're noting that identifying racism, sexism, classism, and other forms of oppression are important in terms of thinking about how to intervene so that we shift the blame from the individual and think about it from the systems level. We've also increased recognition and acknowledgement around advocacy in order to create more of those upstream interventions that really address root causes for Black women. Next slide. We're also seeing that there's barriers to seeking and receiving care, and that's exacerbated by the lack of universal mental health education and screening, particularly during pregnancy, where there's missed opportunities to screen, particularly in Black populations where, missed appointments and other barriers cause a decrease in reporting and diagnosis. There's a story here. I feel like I don't have quite enough time to share, but a lot of our work is done around storytelling and helping people unearth what has happened to them, how that informs their pregnancies, loss, and the layers around kind of compounded weathering, trauma, and stress, and how we can advocate for individuals based on the qualitative data and not just the quantitative data. Go to the next slide. These are the 3 measures that we take: telemedicine, including maternal mental health short-term models, home visiting, and mobile services. Our work happens across the state of New York with a focus on Brooklyn. What we've been able to do to date is impact 5,000 individuals through those 3 mechanisms, and we operate at a unique intervention between gender-based violence survivors and pregnant and postpartum individuals. Next slide. A little bit more about the telemedicine support. This is where we work with obstetricians and mental health practitioners for hard-to-reach communities. You can see some of the outcomes that are related to that. The second approach is home visiting. So we're able to meet people where they're at and bring a home visiting standard of care through our coordinated community response. Postpartum mental health checks and infant mental health checks happen. These are some of the outcomes for the home visiting program, with an emphasis on post-cesarean care as well. And then the third and final approach is the use of mobile health units. You'll see our Sisters van there, which travels across the 5 boroughs of New York through a trauma-informed mobile health unit model. Many of the outcomes are related to bringing concrete items to individuals that offset issues around maternal mental health disparity. So we're really able to intervene, and we want to look at the structural and social determinants that affect Black birthing people, and those specific pathways take an equitable and anti-racist approach. We've been able to do some training and model and demonstrate this for other key mental health stakeholders. And we do not do this work alone. So the last slide is really a feature on our partners. We are a Safer Childbirth City through the Merck for Mothers funding, and we work with universities, hospitals, other community-based organizations, and midwives really anchor our work. You're welcome to connect with me and Black Women's Blueprint through my email or reaching out to us through our website, restoreny.org. Thank you.
Thank you so much, Savannah. Next, we'll have Brittany from Nebraska Maternal Health Program.
Thank you so much for having me. It's a pleasure to be with all of you today. So I'm Brittany Matero. I'm the Vice President of Insena. I go by she, her. I'm here to talk about the maternal health program in Nebraska. This health program really pairs digital solutions with providers to support healthy outcomes throughout a woman's pregnancy and postpartum. By harnessing technology, clinical evidence-based best practices, and community strategies, we're really ultimately looking to improve coordination of care during and after delivery for women, including Black and Indigenous women with high-risk conditions. The partners in this program that have launched it are Sync Health, which is the state designated HIE for Nebraska and Iowa. They connect over 1,135 facilities to timely, accurate health data for over 5 million people. Collective Medical, which is a point-click care company. They are the developer of the technology for the program. They provide infrastructure and point-to-point data, as well as clinical workflow support. And then in Senna, we are a strategy first go-to-market consulting firm for healthcare and health IT, and we really provide strategic consultation for both Sync and Collective Medical, and we have been working to ensure a successful implementation and expansion to drive those healthy outcomes. Today, we're here to talk about health technology and actionable data paired with training, workflow integration, care team transparency, which are all critical to support health providers in understanding and responding to the health needs of women while pregnant and postpartum. Really, this is more than just technology. We're talking about designing to the needs of a community and thinking about the individual women needs. And how do we empower broader care teams, those social workers, doulas, lactation specialists, and community health workers to be part of the solutions and the care coordination that are taking place. So today in Nebraska, we have many of the same issues that you've probably seen in other presentations today. There's been a lot of data that has been shared, and Nebraska is really no different. So we are seeing, Nebraska is ranked 19th for maternal morbidity. According to Nebraska DHHS, 30% of African Americans and American Indians report having no personal physician, which is almost twice the rate of whites. Only 51.9% of American Indians and 57.5% of African Americans had first trimester prenatal care, which compared to the white population who had 76.1%. And, as we've talked about elsewhere, in 2021, Black women's mortality rate was 69.9% compared to an overall maternity rate of 32.9%. And this is important to understand, and why we've really engaged in these programs as we think about how critical it is for that prenatal and postnatal care, that comprehensive hands-on care with physicians who mothers have an established relationship with is critical to positive maternal outcomes. When patients don't have an ongoing relationship with a trusted physician, they seek episodic care. And so we see them accessing multiple facilities, going to emergency departments for care. And this leads really to a fractured patient record, inadequate prenatal and postnatal care, and missed critical follow-up care to ensure coordination, and that their conditions don't exacerbate. And also, missed appointments and a lack of follow-up care are main drivers of high-risk conditions or increased comorbidities. Next slide. And you can go to the next slide too. So we saw a need in Nebraska, and we really wanted to do something that turned the tide. We wanted to have the ability for care providers and care teams to access complete medical records, to receive notifications when their patients encounter a hospital or have an emergency department visit. We really wanted to ensure wraparound support and follow-up care when indicators of most common risk factors in pregnancy and postpartum arise. So thinking of diabetes, hypertension, depression, anxiety, substance use disorder. Each of our organizations are very passionate about health technology and the ability to close gaps, leveraging that technology to ensure adequate care and proper follow-up treatment, along with the power of data to improve population health care outcomes as well. All organizations came together to think about the best way to do this work, and we began a pilot in Omaha, Nebraska. And we started by enabling hospitals and clinics to identify mothers and infants in care of need to facilitate holistic care coordination throughout pregnancy and postpartum up to a year. You can go to the next slide. Our goal, of course, was to support Black and African American and American Indian Alaska Native women through that journey, through pregnancy and postpartum. We wanted to increase care delivery during those most vulnerable times. And the key to this program was really to use technology, again, to help healthcare teams identify at-risk or high-risk pregnant women, mothers, and infants, to enable that improved care coordination before, during, and after delivery. Of course, we know that technology is not all of it, right? There's much that goes into that beyond technology. Just having actionable data doesn't solve. So we were really looking at how do we both enable technology and create the infrastructure to support this work, but how do we also, build training, think about workflows, use evidence-based practices. And so all of this was part of the consideration and part of the program planning to really think about addressing gaps in care, improving outcomes and conditions as well. Next slide. So you can see here a little bit about the inspiration for some of this before it came to Nebraska. Like Savannah, we are huge proponents of stories. And so we have a story here. I hope that these slides will be shared after and you can dig a little bit more into this. But we have seen, women's lives that have been saved due to, again, having data at the hands of a provider and being able to take action on it and understanding how to take action on the data once it's provided. You can go to the next slide. So the nuts and bolts of how it works is that today, a Health Information Exchange, SYNC, provides healthcare providers with alerts to high-risk pregnancy events so that they can refer women to appropriate resources. Those notifications can be in real time. They can be through a text. They can be through a report. They are set up dependent on the actual workflows within a clinic. They also, through the HIE technology, are able to get visibility into chronic conditions, which may impact a woman's health during pregnancy and postpartum, so that they can think about risk reduction strategies. And then finally, healthcare workers are also alerted when a postpartum mom is seen in an emergency department for anything related to diabetes, depression or anxiety, hypertension, or SUD, so that they can coordinate that timely follow-up care and connection into additional services. And part of that, that notification and the information that they're able to see on the patient page also connects them with other care team members, so behavioral health providers, if they have a specialist that they're seeing, so that when they are brought in for that timely, visit or wraparound care is provided through a case manager, they're able to connect in the rest of the care team as well, so that it begins to think of more as that holistic work happening in coordination across the different care providers. So I'm, again, short time, so I'm not going to get into all of this, but a lot of work has happened around really thinking about evidence-based best practices. So making a point to move to ongoing and not episodic as we think of postpartum care, making that insight actionable, like I talked about. So understanding how should we use the data that's coming through, when do we need to engage, how do we change workflows, and reducing the impact of chronic conditions as well by having a better understanding, a holistic view of a woman and her healthcare journey. Next slide. So this program has been, you can go to the next slide. This program has been funded through the CMS's Medicaid Enterprise System MES funding. Sync Health went through the modular certification process and was able to receive that certification successfully. And so the program has actually been wrapped into the state of Nebraska's funding for HIE. They are using it as the vehicle for sustainability. And of course, it's a great vehicle for sustainability as we think about serving, women who are enrolled in Medicaid and CHIP. Some successes that this program has seen is that we've begun to see improvements in collecting data, in working through those workflows. We've had wonderful participation at our training exercises. I don't actually have statistics to give you because we're still working on compiling all of those. This program is just a little bit less than a year old. But within the program, we launched it in Omaha and had so much success that it actually was requested by other FQHCs throughout the state to expand. And so in early this year, the program was expanded throughout Nebraska. And so it is made available to those clinics who are providing care to women throughout their pregnancy and postpartum. And then I will just mention, some of the challenges that have existed in rolling this program out, are the time and resources it takes to roll out a new program, thinking about, again, traditional workflows, which haven't always necessarily included the data needed to be able to do that follow-up timely care and to think about working with an additional care team members and how does that work and how do we collaborate together and who's on first have been some of the challenges and also some of the wins. As you can see here, we have very excited FQHC participants, directors who are so encouraged to be able to get that data and to be able to really offer additional care and services for women. So we are looking forward to continuing to build this out and appreciate your time today.
Thank you, Brittany. And now we will hear from Pamela, Clinical Supervisor at Sacred Families, One Health.
Hello, so nice to be here with you all. What an honor. I am the clinical supervisor for the peer support specialists that we have at One Health. One Health is an FQHC in Eastern Montana, and Sacred Families is a community-based programming that came out of the need to do increased outreach and better support around our Indigenous Native American families, moms, dads, and babies. You can go to the next slide. We started in Bighorn County and are now in several counties in Montana. But again, the mission is looking not only at integrated care, but really the definition of that broadening to our entire community and all of the communities that we work in, and really doing a lot of needs assessment and finding out that there are, again, in our population, many underserved American Indian families and folks not feeling welcome, not feeling comfortable in the healthcare system, intermittent use of the systems, and that coupled with a great deal of substance use and mental health issues and trauma. We really had to get creative to develop some programming just to wrap around all of those needs, to be inviting and really have an open door kind of policy for folks that can use our services. Go ahead, thanks. So this is Montana. We are in the circled area there. So we serve primarily two of the reservation areas, both Crow and Northern Cheyenne, and also serve the surrounding counties, as you can see. So we're also growing. But though we're based there in our FQHCs, we do a lot of statewide outreach, training, and support across the state. Okay, next one, please. So our teams are comprised of, at the very minimum, a nurse home visitor, a community health worker who is focused on social determinant of health needs, peer support specialists. And I'll talk a little bit more about what we're doing with peer supports. Go ahead and go to the next one. Thanks. We do also use as many evidence-based approaches as possible, and have brought on board and trained all of our staff to several parenting curricula, helping women recover and beyond trauma. Also a trauma-based curricula for women and men. Circle of Security, parenting, motherhood, fatherhood is sacred, is a cultural-based parenting curriculum that we use. Our clinics do provide MOUD, medication-assisted treatment as needed. The Sacred Families curriculum that's been developed is a very rich and culturally infused childbirth education curricula that a couple of our home visitor nurses have come up with. And it's very in-depth, and it really engenders both, some of the basic, someone else was mentioning earlier, labor, delivery, prep, but also a lot of work around information around trauma, perinatal mental health issues, and bringing the culturally, rich practices to the curriculum as well. So we also provide lactation feeding support. Again, peer support is a very, very integral part of our team. And one of the most exciting pieces, I think, that's come out of that, and that we're developing more fully, is cross-training peer support specialists who are already trained in trauma, mental health, substance use, and bring their lived experience as healing and recovery doulas. And so they're more specialized around both cultural practices and the challenges that come with substance use, trauma, mental health challenges. And it's been a really exciting part of our team, really kind of the center of our team in a lot of ways. And also with this work, we have done a lot of partnering with our Child and Family Services division to be more proactive in working with families who may fear accessing medical care, prenatal care, based on prior experiences with CFSD and possible, removal of children or fear of that. So that's working really well as well. Okay, next slide. Kind of hit all of this. I do want to talk a little bit more about what our certified behavioral health peer support specialists, that's what all of those letters are providing. Again, the parenting courses, they do classes, they do parenting with, 1-to-1 or 1-to-2 with parents, however they would like that information. They facilitate talking and healing circles, digital storytelling, which has been a pretty wonderful piece of our programming too, where we invite parents to tell their stories digitally, sorry, and help them to create pretty beautiful videos as part of their work and part of our work. We actually have a library of digital stories from the communities that folks that are willing to come forward and tell their story as a pregnant parenting family. We also do a lot of fitness recovery groups. We do a lot of trauma healing groups and education, like I said. And in addition to the healing and recovery doula training, we do an extra Indigenous doula training, so that all of our peers are well trained in again cultural education around birthing and postpartum experiences. Next, please. So we've had a lot of wonderful outcomes and impacts, and many beautiful stories. As the others have already mentioned, a lot of great successes. Really being known for, I think, so much for our outreach as peer supporters, and you know, that bringing their own lived experiences to their own communities. Where in Montana, our communities are rural, pretty small, everybody knows everybody. And so that's been a real impactful bridge into care. So a lot more engagement in perinatal care, which has been wonderful. Healthier pregnancies and births, successful reunifications if there had to be child and family services involved at any level. And then it's really been a springboard for ongoing mental health, substance use, and healthcare. Getting involved in our outreach and health and welfare mental health teams. They're feeling a lot more comfortable coming back for the long haul. And one of the great things about especially our peer support doulas is generally here in Montana, unfortunately, the use of doulas has been pretty minimal and pretty much only available to those that really have financial resources. So what we're able to access is the Medicaid funding for peer support specialists that are also trained as doulas to not only be there to support a birth, but well after, when we know some of the highest risk factors come in postpartum and well beyond 6 weeks postpartum. Okay, I think that's it. Maybe one more. Nope. Okay. So that's us in a nutshell. I could go on, and I know we don't have a lot of time, but happy to be here. Thanks so much.
Thank you, Pamela, and thank you all for providing insight on your programs. I have specific questions for each of you based on the information you shared. Let's start with Savannah from Black Women's Blueprint in New York City. You used a variety of means to reach women in the city, including mobile health vans and home visiting. Tell us more, including how these programs integrate with mental health providers, especially in a big city area like New York. Savannah?
Thank you for the question. I mean, often we think about New York City, and maybe there's folks on the line that are working in New York City as like an oversaturated urban population. Sorry, you can't see me. Urban population. However, there are ways in which many communities, particularly Black communities, are actually more hard to reach than they would be even in rural settings. And it's not that they're not at the grocery store or at church or on their way to the WIC offices or on their way to school or acting in leadership. It's that there's actually such a strong gap between them and medical systems for various reasons. And I touched on a little bit about structural barriers and societal barriers, and then just the fear that our communities are fed about treatment in the hospital, especially undocumented populations, disabled populations, and then just even like populations of like single parents and single birthing people, right? In what world are they going to make like 6 appointments in a week, right? Either for an ultrasound or for a postpartum screening, plus an infant visit, right? And so the reason that we use interventions that actually are used in rural settings is because we understand that a different methodology is needed to reach that population. And I think we have buzz language for that, like hard to reach, disparately affected, right, communities. But it's really about thinking about how to creatively work with those communities. And so it might be a drumming circle or a baby shower, a community baby shower, or a breathwork session for parents, or a fresh food CSA pickup, right? I'm more likely to meet a Black birthing person at one of those than I am to actually meet them in a hospital or clinic setting. And it's not because they don't have prenatal appointments, but because there is a barrier sometimes to keeping those appointments or postpartum screening appointments. And so we've chosen to use cultural interventions to provide clinical support. And so we do that through, of course, the clinicians that we work with, the medical personnel that we work with. We really have trained some of our MD OB partners to be more boots on the ground, to be more culturally sensitive, to take their white coats off sometimes and take somebody's blood pressure in whatever they have on that day, because it actually is an opportunity to do person-to-person connection and to do the healing work that they do, right? And so that, those are the creative ways that we thought about continuity of care, bringing our van around, having other incentives for community members, and having things for their whole family, right? Like, not only do you get a blood pressure cuff, but like, is there an elder in your home who needs one? Do you know how to check your baby's temperature? Those different kinds of things. So sending people home with life-saving devices that are for the whole family. And that really is a midwifery model of care that we try to implement and utilize. And so sometimes, like, interrupting structural racism or health disparities and inequities literally just looks like meeting people at their home or knocking on the door or meeting them at the grocery store. So I might make it sound simple, but it is actually still really hard work and requires a lot of coordinated community response.
Thank you so much for that insight, Savannah. Next, Brittany from Nebraska Maternal Health Program. Tell us more about the technology you used and how digital solutions are improving postpartum care for postpartum women receiving Medicaid services. Brittany?
Yes, thank you so much. So Sync Health leverages a tool that's provided, a solution that's provided through Collective Medical. The primary piece of the technology is actually facilitated by admit discharge transfer data, which can include demographic information, it can include diagnosis codes, other information that populates that and that pulls it into the platform and then is able to build alerts off of it. But they also have a patient a portal that you can go into and you can see a little bit broader of data. So they're able, like I said earlier, to bring in care team information if they have that information about who's actually connected and serving a mom or a woman, information that might come from other sources as well, like a managed care organization who is interacting with that mom in some way or capacity, who has, put in their care team notes. And so they're able to pull up and see that information and use it. And so this allows them to both be proactive. They can get in, they can see this information prior to a woman's visit, and they can, make decisions based on the information that they can see there. They're able to, if there's an emergency department visit that happens during pregnancy or postpartum, they're able to get a notification of that so that they can immediately, call and schedule a follow-up appointment. So maybe they know, the woman has given birth in the last, several weeks. They have an appointment scheduled for follow-up, but it's 2 weeks out. She's had a visit though for hypertension. They know that they want to get her in as soon as possible. And so they're able to, they get that notification, they're able to call her up and they're able to see her, immediately. They're also able to make decisions on some of that for additional care. So there's a lot of work happening in Omaha, for example, in coordination with Omaha Better Birthing Project and IB Black Girl, that are community supports that are in place and available for women, and they can connect them into services, and help to facilitate, again, making sure that it's not just an episodic visit, but it's ongoing. And how do we really think about that coordination of care that's so essential, but with the right coordination of care, right? Again, Savannah was mentioning, those relationships and trusted individuals, and how do you need to meet them where they're at versus always asking them to come in, right? And they can take all of those things into consideration because they have the data there in front of them that helps to prompt those actions. But as I mentioned at the beginning of my presentation, technology is wonderful and data is wonderful, but you still have to take an action. You still have to think about those workflows within your clinic. You have to think about training. You have to think about, your community partners, your doulas, your lactation specialists, all of those, and how does the whole system work together? And, and that's the work that this program is really working to do.
Thank you, Brittany. Thank you for that insight. Now, Pamela, from Bighorn Valley Health Center, as you told us, you serve the American Indian community. Tell us why you chose to use peer support specialists to support your program. Also, tell us more about interactions with medical providers or the health care system. Pamela?
Sure. So as an FQHC, One Health is a comprehensive medical clinic providing whole variety of medical, dental, mental health, substance use supports to anyone, regardless of ability to pay. And the advent of community-based services as a part of the FQHC is fairly recent, the last couple of years. And that really did start with bringing in some training and opening that up to really anybody in the communities that had an interest in working as a peer support specialist, learning about what that is, and really with the idea of, everyone works probably the best with someone with whom they're comfortable, have things in common, someone who's been through, similar experiences. It's just so much less threatening. And so in one of our efforts of getting services out to the community, the training and the push to bring peer supporters on was really bringing the community into the clinic setting too. And so our initial training, I think we had a very good turnout. 26, I think, new peer supporters were trained, and this is a couple of years ago, and peer support has not been a Medicaid billable service in Montana for very long, a few years. And so really started to cultivate a good group of folks that really did bring their lived experiences as their major strength to the table. Having gone through a lot of trauma, substance use, mental health challenges, and continuing, on their own recovery journeys, which really never ends. But again, knowing the communities as well as all the folks in these small communities really do, it's just been such a lovely bridge of ease and comfort by coming in that door. Maybe folks have never even come to a clinic. Maybe they only know about, Indian Health Services and can't get, all of the services that they might need out of there. And so it's been just a real good education and outreach bridge. to help people feel more comfortable coming to access those services and really all of the other services that One Health as an FQHC offers. And out of that work, we've also started, we call it a peer support training and learning collaborative. That's a training hub that's open to peer support specialists all across Montana, specifically those that are working with parents, babies, and the perinatal period, and the different challenges that brings. So we're doing, one of the great things about being in a big state like Montana that only has, a few people compared to New York and so many others, is that we really, through relationships across the state, can work together. And so we're really excited about the peer support piece getting richer and bigger. And again, as I talked about earlier, with them being cross-trained as certified doulas, healing and recovery doulas, it really gives us a mechanism for reimbursement, as well as just ongoing longer-term care and support, kind of eyes on mamas and parents and new families in general, beyond the birth and into that, postpartum period there, where we tend to fall off in terms of our ongoing support to especially these moms that have so many risk factors. And so it's been a great long-term relationship that the peers really bring.
Thank you so much for your insight, Pamela.
Sure.
And thank you so much to all of the panelists for the rich information that you have shared with us today and for your innovative work. I think we may have a few questions in the chat for you. I will turn it over to Ebony now, who will take any questions from the chat. Thank you, Ebony.
Hi, everyone. If you have any questions, go ahead and use the chat feature, drop your questions in there. I will read them off for the speakers to respond to. I'm not seeing any just yet. Go ahead and drop them and I will monitor the chat for that.
Okay, awesome. In respect of time, I'm going to share my screen, and Ebony, just let me know if any questions pop up, and I'm happy to stop sharing. And
Perfect.
we can entertain the questions. Okay. Okay. Thank you, panelists, and thank you, 2020 Moms, for inviting the Office on Women's Health to be a part of today's meeting. If you would like to learn more about the office's upcoming observances and announcements, including winners of our other challenges focused on reducing disparities in women's health, please visit our website and sign up to receive the Office on Women's Health email alerts. To sign up, go to womenshealth.gov, scroll to the bottom right corner of the website and add your email address and select subscribe. You will receive a follow-up email to select the types of notices you would like to receive. Additionally, our office invites public and private organizations to become women's health champions. Women's health champions can be public and or private organizations, such as those at the state, local, county, and tribal levels, non-governmental organizations, nonprofit organizations, businesses, academic organizations, organizations that impact health outcomes, philanthropic organizations, and tribal organizations that identify themselves as being aligned with and or promoting the goals of the Office on Women's Health observances. Organizations that work to improve health outcomes and or social organizations that work with and or have access to large populations of women may apply. You can access the Federal Register notice for more information. I will include that link in the chat, or you can send an email to womenshealth@hhs.gov and ask how you can become an Office on Women's Health champion. I am going to switch back over to the slide as I am able, just to walk everyone through this. Bear with me, I'm sorry. Yeah, a second. Just want to make sure everyone was able to see the slide that we shared. And here we go. Okay, so this is the first slide, and in this slide are our national observances. We just we just celebrated National Eating Disorders Awareness Week from February 27th through March 5th, and National Women's Health Week, which is, so sorry, my screen here is not cooperating with me, but that's
We can
okay.
see it, Alicia.
You can see it? Okay, great. Yes, National Women's Health Week, which is May 8th through 14th, the week of Mother's Day. And then this, we had another event that recently passed on March the 10th, National Women's and Girls HIV/AIDS Awareness Day. And upcoming in October, from October 16th through the 22nd, we have National Women's Blood Pressure Awareness Week. And to reach us, and I'm so sorry, let me go back. I clicked too quickly. You can connect with us on several platforms. You can connect with us on girlshealth.gov, Facebook, Twitter, YouTube, and Pinterest. And I will include that Federal Register notice on how to become a women's health champion in the chat box. And if there are no questions, thank you again, everyone, and have a great afternoon.
They have some questions.
They have some questions. Okay, great.
Yeah.
Thank you, Ebony.
Yep. So I will start. This one is for any of the panelists. Have you run into any challenges or barriers with getting reimbursement for your program services from private payers and or Medicaid? And that one is directed to any of the panelists.
Well, I'll jump in. I did sort of mention this already, but so far, doula support is not in our Medicaid state plan, so it's not reimbursed through Medicaid. Unfortunately, that's being worked on, but that's one of the reasons why we decided to kind of go through the peer support route, because those services are Medicaid billable, but definitely we haven't found any private payer, third-party insurances that are covering either of those here in Montana. So there's a real need to do a lot more education and work on policy with insurance coverage for sure.
And I would say, I appreciate that, Pam. I would say where there has been Medicaid reimbursement across different states in the US, it's not been equitable. Like, it does not meet the standard that doulas deserve. Like, we need more expansive reimbursement packages, and also for them to see the different kinds of services that doulas do as reimbursable practices.
Yeah, agreed.
This doesn't have to do with reimbursement, but I will say in Nebraska, they've also been trying to consider like other ways outside of rates can we be supporting doulas. And so childcare grants, making available those, as an assistance to help. And then I mentioned our program it's actually sponsored entirely through Medicaid for the technology. So different than rates, but a good partnership when thinking about how to get technology into the hands of others.
Thank you all. There's one more question I see listed. How can we as healthcare people soft pedal these disparities with our clients about these disparities so as not to scare our folks? I'm sorry, I totally chopped that up. I'm going to read it one more time for you all. My apologies. My cursor was in the wrong space. How can we as healthcare people soft pedal these disparities with our clients so as not to scare our folks? And again, that's for any of you all.
Well, I'll jump in again, and I know this is kind of, I keep harping on this, but it's kind of the point of, what I was talking about that we're doing in Montana. I've just become a true believer in peer support work, and how that can, these folks can so be, like I said before, a bridge to people in our communities that really for one reason or another aren't accessing healthcare, or have had traumatic experiences with systems, and really it's so about relationship and trust that having citizens that just kind of know through their own experience both how some of these experiences feel, but also can really kind of hold some hands, and be right alongside someone as they reach out and do access other medical supports that are needed. And we do, we do speak directly about how underserved and our Indigenous population is in so many ways, and how much more laden that population is with so many layers of historical and other traumas, and so at risk, that they deserve all of the support and help that we can give them. So I think that, again, I think just the peer-to-peer stuff has been really, really helpful to normalize it,
Thanks, Pam. Anyone else wanted to jump in on that?
I think also partnering with our community-based organizations. I mentioned, in Omaha, I Be Black Girl. It's, really important that we're building these bridges, right? And that we are, I love the peer supports. I love the local-based doulas. We have so much to learn in healthcare about, delivery and partnership and helping to build trust. I love some of the examples Savannah gave at the beginning, about how, they are going out and meeting people where they are. And I think that, where we can pull those things in and consider them as part of our healthcare network, that, those are really important for us.
Thank you, Brittany. Savannah, are you coming off mute? No pressure. Okay.
No, I really think Brittany and Pam said what I would say. So thank you, Ebony.
Thank you. I'm not seeing any more questions in the chat, Alicia. I want to toss it back to you to close us out.
Absolutely. So everyone, thank you again for the rich conversation, discussion, information, and have a great afternoon.
Thank you so much.
You're welcome. Thank you.
Thank you.